This infographic serves as a comprehensive clinical roadmap for epilepsy management based on the updated 2025 ILAE, International League Against Epilepsy, framework. It synthesizes clinical classification, mechanism-based pharmacotherapy, initial management algorithms, and vital safety profiles into 5 distinct clinical pillars. 1. Diagnosis and Classification, 2025 ILAE Framework. This section outlines a modern shift toward a simplified, network-based taxonomy for classifying seizures. The 2025 ILAE taxonomic shift, epilepsy classification, has evolved from a complex system of 63 recognized seizure types down to 21 consolidated types. This transition prioritizes clinical consistency and a network-based understanding of seizure propagation rather than isolated anatomical focus. The new consciousness classifier, rather than relying loosely on awareness, the operational definition of consciousness is now explicitly defined as the intersection of 2 distinct clinical components: awareness, the objective ability to recall events; responsiveness, the physiological ability to react to external stimuli. Focal versus generalized seizures. Focal seizures originate within networks limited to one cerebral hemisphere. They are further subcategorized by whether consciousness is preserved or impaired. Generalized seizures rapidly engage bilaterally distributed networks. Clinicians should assume impaired consciousness by default in these presentations. 2. Mechanisms of action, MOA, a visual matching guide. Selecting an anti-epileptic drug, AED, requires matching the clinical seizure type with the cellular mechanism of the drug. Sodium, Na-carrot plus, channel blockers, phenytoin, carbamazepine, lamotrigine. These agents prolong the inactivated state of voltage-gated sodium channels, preventing the high-frequency repetitive sustained neuronal firing characteristic of an active focus. T-type calcium, Ca-2+, channel blockers, ethosuximide. These specifically block T-type calcium channels localized in thalamic neurons. This mechanism is considered the gold standard for treating absence seizures by disrupting rhythmic thalamocortical spikes. GABA enhancers, benzodiazepines, phenobarbital. These agents augment inhibitory neurotransmission. They either modulate chloride, Cl-carrot, channel conductance to hyperpolarize the membrane or directly inhibit GABA transaminase to increase synaptic GABA availability. SV2A ligands, levetiracetam, brivaracetam. These bind to synaptic vesicle protein 2A, SV2A. By doing so, they modulate and reduce the exocytosis of excitatory neurotransmitters into the synaptic cleft. 3. First-line treatment algorithm. Empirical drug selection is guided strictly by the classified seizure phenotype, focal, partial, seizures, * primary recommendations, lamotrigine, levetiracetam, carbamazepine. Effective alternatives, oxcarbazepine, lacosamide. Generalized tonic-clonic, GTC, seizures, * preferred first line, valproate, levetiracetam, lamotrigine. Long-term maintenance, phenytoin remains a staple, particularly for managing the stuporous post-ictal phase. Absence seizures, * drug of choice, ethosuximide. Clinical contraindication, carbamazepine and phenytoin must be avoided, as sodium channel blockers can paradoxically worsen absence seizure activity. 4. Status epilepticus emergency protocol. Time is brain. This protocol outlines a strict, time-delimited escalation pathway to prevent progression to refractory status. Phase 1. The initial 0 to 5 minutes, first-line benzodiazepines. Immediate administration of rapid-acting GABA enhancers is critical. Preferred, IV lorazepam, 4 mg. Alternative, if IV access is unavailable, IM midazolam, 10 mg. Phase 2. The 5 to 15-minute escalation, second-line non-benzodiazepines. If seizure activity persists past 5 minutes, immediately transition to non-benzodiazepine secondary agents. Options include levetiracetam, 60 mg per kilogram, valproate, 40 mg per kilogram, or fosphenytoin, 20 mg PE per kilogram. Critical dosing accuracy alert. Audits indicate that up to 80% of status epilepticus patients are underdosed in emergency settings. Clinicians must aggressively titrate to full therapeutic doses immediately to minimize neurological injury. 5. Critical safety alerts and regulatory mandates. High alert safety warnings emphasize pharmacovigilance and personalized medicine. Valproate teratogenicity warning. 2026 expanded updates strongly highlight elevated risks for autism, intellectual disability, and ADHD in offspring exposed in utero. Valproate is highly contraindicated in women of childbearing potential unless utilized for entirely non-refractory epilepsy where no alternative exists, or for specific non-migraine, non-responsive indications. Carbamazepine pharmacogenomics. Mandatory genetic screening for the HLA-B1502 allele is required for patients of Asian descent prior to initiating carbamazepine. Carrying this allele puts the patient at extreme risk for life-threatening cutaneous toxicities, specifically Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, TEN. Lamotrigine titration and SJS. To further minimize the risk of SJS, lamotrigine requires a very conservative, slow dose escalation. This vigilance must be doubled if the patient is on concomitant valproate, as valproate significantly inhibits lamotrigine metabolism, dramatically clearing the path for toxic drug accumulation.